Okay. Well, hello everyone. I'm so excited to see some people here. My name is Elise. I'm the current vice president of Pacific Northwest Wilderness Medicine, who is hosting this talk. I just wanted to start off with a brief intro of what our organization is. We are a coalition of the six medical schools in the Pacific Northwest. Basically run entirely by medical students for healthcare students in the Pacific Northwest, aimed at increasing wilderness medicine education in the area. So we host an annual conference, which is coming up this year, January 9th, 10th, and 11th on Mount Hood. We hope that you will all be there. And then we have a Med War. It's a wilderness medicine race that we do every year, which is actually coming up the next weekend, I believe October. Oh gosh, I can't remember if it's the third or the fourth. Yeah, it's one of those two. I think the fourth. Um, but it's going to be super exciting. We do that race every year. And then now we're hosting these quarterly talks as well. So we're just really trying to get more wilderness medicine education for us in the Pacific Northwest. So if you're interested, please follow our Instagram at PNWMed, or our website is pnwmed.org, and you can check us out for more information. And then we'll go ahead and get started with this talk. So this is Dr. Lauren Snyder. She grew up in Southern California, rock climbing, fishing, water skiing, and camping, and fostering a love for outdoor activities. For medical school, she moved to new environments and new seasons, including hiking and backpacking in the Phoenix area, Sedona and Havasupai regions of Arizona. And then she moved to New England for residency and a wilderness medicine fellowship, which was interesting for a SoCal native, but Dr. Snyder fell in love with 4 seasons of outdoor adventures and explored the beauty of the East Coast, from the Outer Banks to Maine. Dr. Snyder completed her wilderness medicine fellowship in 2019 and her FAWM in 2021, and she's led wild med trips to Kilimanjaro, Guatemala, the Bahamas, Costa Rica, and throughout the States. Dr. Snyder currently works in Portland, where she continues to find outdoor adventures in the vast Pacific Northwest with her canine sidekicks, most importantly, Gunner and Bailey. Dr. Snyder, thank you so much for being here.
Awesome. Well, thank you so much. And thank you guys all for joining. I was just chatting that I didn't quite realize this was a Saturday night when I agreed to the time. Like I said, I'm boring, so it doesn't really matter. But I thank you guys all because I know you have lots of things going on, and doing anything extra in your time off is always a big ask. So I appreciate you being here. Yeah. And this is a very informal talk. So let's see, I'm going to get started. But I don't know in presentation mode. I'm not sure that I can see the chat. So if you have questions, please interrupt me. This is meant to be learning and fun and interactive. So by all means, if you have a question or clarification, just interrupt me. But today we're talking about diving. Out of curiosity, does anybody here dive? Is anybody scuba certified? Excellent. I didn't get certified until right before a couple. Nice. I didn't get certified until right before my wilderness medicine fellowship. Always loved the water, but I've only been a handful of times, but I find it really enjoyable. It's really peaceful. So if you like the water, definitely give it a try. It's really nice. But of course, today we're talking about diving injuries and the things that can go wrong. So uh, just kind of an overview of what we're going to talk about today. I'll give a brief intro, although Elise kind of already told you all the things I was going to say, but just a little bit about me, and then we'll talk about diving, the different types. I hate to say it, but like a little bit of physics, just so the diving stuff makes sense. And then, of course, the injuries, how to manage them, and just things to consider if you come across anybody who may have a diving injury. So, as Elise mentioned, this is where I work. It's called Portland Adventist. It's one of the hospitals here in the Portland metro area. We do take medical students from OHSU. So I hate to say for those of you who are not OHSU students, it might be a little bit hard to coordinate a student rotation with us. But if you get a chance to come and see us, we're fun. We're a really fun group, and we do a lot of crazy stuff. I think we just have really sick patients in the Portland area, and they all seem to come to our hospital. I know that's not true, but that's just what it feels like. And I'm mostly a nocturnist, so this picture is our ambulance bay at night. But of course, I like to be outside, which is why I'm here, which is why you guys are here. And so, growing up in Southern California, I was at the beach all the time, surfing and swimming and boogie boarding and all of that. And just from a really young age, I just loved being in the water. But of course, when I moved to the desert for medical school, there's water, but there's no beach around. And so I really kind of fostered like the camping, hiking part of my outdoorsiness, I guess. And then I moved to the East Coast, which was awesome, but also weird. Getting used to four seasons and how to dress for it and how to drive in it and all of that. But it was really great because I got to experience outdoor things in winter, which is actually still one of my favorite things. It's really great. I did my training in emergency medicine at Bay State Medical Center and stayed there at the same hospital, Bay State, for my wilderness fellowship. Then, of course, I moved to Portland. It's really fun that you mentioned the MedWar, and I know it's coming up, but my first wilderness medicine experience was actually a MedWar event when I was a medical student that was like doing my sub-Is. I was in Michigan and they just happened to have this MedWar event and they told me about it, asked me if I wanted to like help out. And of course I was like, yeah, I mean, a day outside, much better than in the hospital. So my little station was, I can't remember all the specifics, but there was a bear attack. This was the bear. And it was just so cool. It was so fun. And I think that was really the first time I realized that having like outdoor hobbies and an interest in a career in medicine really had a lot of overlap. And so I think this was like 2014, if I remember correctly, when I was in Michigan, and it was just so, so cool. So I'm so happy to see that MedWar is still going on and there's events all over. And I can't make it this year to the one that's coming up next week, but I'm hoping that some of you guys will be able to make it because it's super fun as a participant, but also if you wanted to like volunteer and help out, is very, very cool. But of course, we're talking about diving today, so let's get back into it. In terms of diving, I think, when I think of diving, I always think of scuba because that's just kind of what comes to mind. You got the regulator in your mouth, a tank of oxygen, not oxygen, but like compressed air on your back. And so, of course, that is diving, but free diving also kind of lives under that umbrella. Free diving, of course, just means you're holding your breath going underwater. If you guys swim, this is what you do when you're swimming, but there's a whole competitive world with free diving, and there's actually a few documentaries if you're interested. I think on Netflix or some of the other streaming services, but it's a fascinating world. Yeah. The other types of diving that exist are probably not things that you will likely encounter. These are more like industry, military type diving. Surface supplied diving, as the name implies, means that your air supply is on the surface and it's connected to a tube or an umbilical, and that's how you breathe. Saturation diving essentially means you either stay at depth or stay in a pressurized environment so that you can stay deeper, longer, and do whatever task it is, whether it's research or military tasks or whatever. Um, Excuse me. Again, these are not super common, or at least not that I have ever heard of, other than, in a learning sense. So I think if you were to encounter either of these, you would probably be either involved with the military or some sort of like company or industry that does a lot of underwater work. But just know that they exist. Okay, here's the boring part of our lecture, physics. I'm going to try and make this as simple as possible because I don't know if you guys are like me, but physics is maybe not my favorite or strong suit when I was learning about it, but it is totally relevant to diving, and I think a really basic understanding can be helpful. So, water is a little more dense than air, and so it exerts a little bit more pressure. Um, you can imagine how if you go underwater, that pressure increases, right? Even if you're just swimming into a pool, you can kind of like feel your ears need to pop if you're like in the deep end or something like that. And so there's some terminology that we use to kind of describe the pressure and the depth and how much force is, kind of putting pressure on your body. And we use the term atmosphere. So for most of us right now, I'd venture to guess, we're not underwater. So on the surface of the Earth, we have the atmosphere above us, kind of succumbing to gravity and acting a force on us, right? There's pressure on us right now. We're used to it because this is where we live. Um, but that is one atmosphere, right? The column of air over us exerting pressure down is one atmosphere. If we go underwater, not only do we have the air above us, but we also have the water above us also exerting pressure downwards. So you can imagine how the pressure kind of increases as you go deeper underwater. For every 33 feet of seawater that you descend or go down, you have one atmosphere of pressure. So this little pictorial is kind of helpful, right? At the surface, you have the atmosphere above you. If you go 33 feet down, you have two atmospheres, that the, 33 feet of water plus the air above you, et cetera, et cetera. And this is just kind of the terminology of, how depth and pressure is discussed with regards to diving. But let's see, more boring stuff. You can also imagine how as you go deeper, the pressure increases, right? We can feel that. We can feel it on our body. And here's where Boyle's law comes in. It says that pressure and volume are inversely related. So if you increase the pressure, you decrease the volume. So you can imagine this little gas bubble, right? As we go underwater, as we go deeper, the pressure increases. So that pressure is going to push, 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 and kind of make that gas bubble smaller. Like the size of it, the volume of it is going to be smaller. You can imagine how this is starting to relate to like diving related injuries, right? Um, the next two, actually, here, we'll talk about this one first before we go on to the next one. This graph, I think, nicely shows kind of that principle, Boyle's principle. As you go deeper, the pressure increases, the volume of that gas bubble gets smaller, right? It kind of compresses. Pay attention to this. Oh, is there a question? What was that? Oh, sorry. If you do have a question, please by all means speak up. But pay attention to this kind of at the surface, right? This is at the surface, one atmosphere, and even at 33 feet, kind of that two atmosphere, right at the surface. Look at how much difference there is in size in terms of volume of that gas bubble. It shrinks by about 50% or grows by about 50%, depending on if you're descending or ascending. And that has big implications because the size of that gas bubble, as it's either compressing and pulling or expanding and pushing, can cause maybe some drama in the body, depending on where this gas bubble exists. As you go deeper, of course, there's still change to the volume in the gas bubble, but it's just so pronounced at the surface. And that's why a lot of these injuries tend to happen in relatively shallow water, or they can at least. We'll talk about it. Um, but yeah, I just like this graph because it just like makes sense to me. You go deeper, the pressure increases, it pushes, that gas bubble gets smaller. As you increase or as you ascend, the pressure decreases and that gas bubble kind of re-expands. These next two laws are interrelated, and to me, my simple mind, they get a little more complicated, but the basics are Dalton's law has to do with partial pressures and total pressure. So air, for instance, is a mixture of gases. So the pressure on that air is proportional to each of the gases that make up that mixture, right? So the air we breathe is mostly nitrogen, 78%, and then 21% oxygen. So the partial pressures of both nitrogen or oxygen are proportional to the percentage of the makeup of the gas. Also, it has to do with like the size of the molecules and things, but we won't get into that because that's not totally relevant or not totally necessary to understand for what we're going to talk about today. But again, you can understand that if the total pressure increases, the partial pressure also increases, right? Because they're related, they're proportional. This last law, I promise, last physics law we're going to talk about is Henry's law. And this one says that the partial pressure of a gas is also helps determine how much of that gas gets dissolved or is dissolvable into a liquid. Um, this comes into play, as you can imagine, because as we go deeper, the pressure increases, which means the partial pressure increases, which means that that gas, whether it's nitrogen, oxygen, or both, is more likely to dissolve. And gas being dissolved in the body has some effects that we'll talk about when we talk about the injuries in just a moment here. But you can see how pressure, partial pressure, dissolving a gas, whether it's in more of a liquid form, kind of dissolved in our tissues, or in a gas bubble, really sets us up to understand these injuries. I know that was like wildly complicated, and honestly, I have to review this every time because I hate physics, but it makes sense if you kind of understand those really basic ideas to talk about injuries. So now we're going to talk about what you actually came here to talk about was dive injuries. I like to think about these as during different parts of the dive, as you're descending, when you're diving, as you ascend, and then of course when you get back to the surface. If you can kind of, think about when or where the injury occurs, you might be able to predict, or I guess during which part of the dive the injury occurs might help you predict what's going on and what caused the injury. So I think it's kind of helpful, at least in my mind, to separate them out in this way. So as we're going down, again, you can imagine how we're going down, that pressure is increasing, that gas bubble, the gas in our body is kind of compressing and getting smaller. And so as it's pulling, as that gas bubble gets smaller, it has this negative pressure. It's pulling on the things next to it. And that can be painful depending on where this gas bubble is. Our body's got some squishy bits, but it's got some air bits too. And so the air in our body, or at least the areas of our body that have air, are most susceptible to this injury of descent, right? So think about air in our body. I think about our sinuses, our inner ear. There's gas in our gut, but that, our gut's a little more squishy and malleable. Unlike our sinuses, which are pretty rigid, or our inner ear, which is kind of this like really confined space. So again, as we go down and that pressure increases, that air will kind of shrink in size and will pull on the things around it. So we get trauma to the ear. So the middle ear, right? As that space gets smaller, physically smaller, and the volume decreases, it can pull on our tympanic membrane. For those of you who dive, you know that, a problem with your ears is kind of a big deal. Not only because it can be painful and uncomfortable, but if that tympanic membrane ruptures, you're essentially going to give yourself a cold caloric test. And um, excuse me, if you guys maybe remember from some of your med school studies about cold calorics, it sounds terrible. I don't know that we commonly do this in the ICU anymore, but this used to be one of those noxious stimuli, like brain death type tests, right? You can squirt cold water in the ear and see if people have nystagmus and vertigo. It would be horrible, absolutely horrible to rupture your TM and have a cold caloric test essentially while you're diving. That just sounds terrible because you can imagine how if you're diving, you get vertigo, maybe you panic because I would if this is happening underwater. And then you're gonna, logic goes out the window and you might ascend without, doing your decompression stop, all kinds of stuff. Also, it would just be really painful. And you can't dive anymore with a ruptured TM. So, having your, equalizing pressure in your ears is a really big deal. And so, of course, you guys are probably familiar with doing this, maybe from swimming or diving, but maybe also going on a plane, right? You can kind of like open your jaw, or maybe you pinch your nose and kind of put pressure to try and equalize the pressure across that middle ear. If you don't do that, again, it might just be painful and cause a little bit of injury, but at worst, it can cause rupture, which would be terrible. So this is one area where that negative pressure squeeze would be affecting our body. I mentioned sinuses, kind of, the sinuses in our face. It would be the same idea. The air in those areas will be kind of pulling in that negative pressure way. Um, and if you have any congestion or injury or malformation to your nasal passages, it might just be painful, cause some bleeding or irritation, or have symptoms maybe similar to a sinus infection, right? That like fullness and discomfort kind of in your face. Some divers will use decongestants before they dive, which I think is generally not recommended. And this is also a big reason why it's not recommended to go diving if you're sick or have been sick recently and are still kind of congested. Other barotraumas can exist. I mean, again, anywhere that there's air in your body, as that gas bubble gets smaller, it's going to be painful, right? If you've got a dental infection, there's little air in there, you can have tooth pain. The air under your mask, if it squeezes too tight, I've seen people with like petechiae on their face or subconjunctival hemorrhage on their eyes. Not dangerous, just uncomfortable. And so a lot of times, you might want to equalize the pressure, blow some air out of your nose to decrease that pull on your face. It can also, if there's like air bubbles trapped under your wetsuit and squeeze, you can get like little like bruises and marks on your skin too. But all to say, anywhere in your body that there's air, it's going to pull and it might be uncomfortable. I think the most dangerous one's probably the inner ear, but it can happen anywhere. So now as we continue our dive, we're at depth. So now we're talking about what can happen when you're at the bottom. Um, Nitrogen narcosis is rare, but really scary. And the way that this happens is, remember now, of course, we've said this a couple times. You're in the water, there's increased pressure, there's increased partial pressure, which makes that nitrogen more likely to kind of dissolve into our body and into our tissues, into our blood, into our muscles, all of it. If we get too much nitrogen building up in our system, it can be dangerous. because nitrogen has a little bit of an anesthetic effect, but it also essentially makes us drunk. It can make us have poor judgment, feel euphoric, have like impaired fine motor skills, all of which obviously maybe not that great when you're, I mean, at any time, but like especially when you're diving, right? You want to be like with all your faculties, following dive tables, keeping track of your buddy, all kinds of stuff. Thankfully, this is rare. In order to have the physics line up to make this likely, you really have to be pretty deep. As you can see here, it's like 4 or 5 atmospheres. So like 100 to like 150 feet of seawater. So it's really, really deep. If I remember correctly, I think the basic level of like a diving certification, I think is to 80 feet. So generally speaking, unless you're a very experienced or professional diver, most people aren't going to be going quite this deep. Accidents happen. It's sometimes a little bit easy to like lose track of your depth and your buoyancy gets all out of whack, so it can happen. But generally speaking, again, this is rare. It shouldn't happen, but it can. And the big danger to this is just it's just really hard to pick up. You can imagine that if you're like almost intoxicated, you may not notice it within yourself. So hopefully your dive buddy is like keeping tabs on you and can kind of tell that like maybe something's a little bit off, or just like sees you fumbling and can make the suggestion that you guys ascend. Thankfully, as you ascend, this condition generally kind of gets better on its own as that nitrogen kind of dissolves back into, or I guess resolves, how it gets out of the tissue, kind of washes out of the tissues and kind of forms gas again. Um, it gets better and this condition resolves. But again, it's just really hard to recognize. And I would assume that it would be hard to recognize it in yourself. So this is really something that your buddy or the people that you're diving with would hopefully pick up on and suggest that you ascend. Very similarly, you can have the same thing, but with oxygen. That increased pressure, partial pressure causes oxygen to kind of dissolve in our body. And I think the leading theory is that the free radicals from the oxygen kind of cause like an inflammatory response and just kind of damage throughout our body, which leads to oxygen toxicity. There's two main types, central nervous and pulmonary. Thankfully, the central nervous one's pretty rare. As you get oxygen building up and those free radicals affect the central nervous system, you're going to get some pretty scary symptoms like convulsions or seizures. Goodness. Visual changes would also honestly be really scary as you're diving. Um, this one seems also pretty rare. You'd have to go exceedingly deep. I mean, over 200 feet of seawater depth. I'm not sure that that's possible, certainly not from a recreational standpoint. Um, so really, this is probably going to be a combination of things that lead to CNS toxicity. Maybe it's just you're the rare person that's prone to this, or maybe there's something wrong with like the mixture of the gases that you're breathing. Um, Again, thankfully it's rare, so it shouldn't happen, but can. And really, this is supportive care and just ascend. The more common one is pulmonary toxicity. The oxygen and free radicals kind of affecting the lungs and mostly causing respiratory symptoms, kind of that burning when you breathe or cough, um, almost kind of just like you're sick. I mean, you're not because it's not an infection, but kind of symptoms like that if you wanted to think about it that way. Again, mostly supportive care, and this resolves with time at the surface. So if this happens, you're probably not going to be diving until this feels better, because of course, why would you want to dive if it hurts to breathe as you go underwater and not breathing through a regulator? But again, oxygen toxicity a little more common than the nitrogen narcosis, but mostly from a pulmonary standpoint. All right, so now we've descended, done our dive, and now we're starting to come back up. And this is essentially all of the injuries from descent that are now reversed. So now as we come back up, the pressure is going to decrease, meaning that gas bubble is going to re-expand, right? And remember that little picture of the gas bubble at 33 feet and then at the surface? So really right in that last little bit of your dive is when those gas bubbles are going to like almost pop open, which is why following your dive tables and really doing those decompression stops for the full amount of time is the safest way to dive. However, even if you're doing that, sometimes these things still happen. Just, I don't know. I don't know if we really know why, but some people are more prone. So But you can really try and decrease your chance of most of these injuries by following dive tables. But so all of those areas in our body that have gas, middle ear, the sinuses, the air in our gut, all those gas bubbles are slowly going to get bigger in size. And so you'll think about almost like the mass effect, like pushing. So you might have some pain in your ear or your sinuses again as you ascend. Equalizing those pressures is a little bit easier on ascent. Some people, gosh, it's like, oh, it hurts, it hurts. But then, like, maybe an hour after you get back to the surface, you're like, oh, my ear finally popped. So it's not quite as dangerous, but it can be uncomfortable. You still can rupture your TM on the way up, although it's certainly much, much less common. But things like bloody noses or some pain in the sinuses are just a little bit more common as you come up. Not dangerous, just annoying mostly. And then this last bullet point, I think I just found it absolutely hilarious. But of course, there's gas in our GI system because there just is. And as we go down, the gas kind of shrinks and gets smaller, so no big deal. But as we come back up, those gas bubbles are getting bigger. So some people describe kind of like a bloated feeling or feeling like they have to pass gas. And this description, I can't remember where it's from. It's from one of the wilderness medicine texts, but I thought it was just too good to not include. So for gas in the bowel that starts to expand as you come back up to the surface, the standard cure is evacuation of the gas through either of the two anatomical venting orifices with the resultant decrease in pressure. So basically, if you can off gas from your GI system, you'll feel better. And I don't know why, but I think that's just really funny the way it's worded. Um, the biggest, I guess, danger, or one of the big dangers of injuries that can happen as you ascend is in the lungs. For those of you that do dive, you know that you are always taught anytime you ascend, what are you supposed to do? Exhale, right? You're supposed to like ooh, kind of blow little bubbles. For those of you that don't dive, they harp on this all the time as you're certifying. Anytime you come up, you don't want to hold your breath and pop to their surface. Because think about it, that gas bubble when you're underwater is kind of small, but as you go up to the surface, pop, that gas bubble is going to get bigger. If you hold your breath, there's nowhere for that air to go, and it's going to kind of put all this pressure in the lungs and can cause danger, or I guess injury in the lungs. So you can rupture alveoli, you can cause a pneumothorax, pneumomediastinum. I mean, that air has to go somewhere. So the best place for it to go is to leave your body by exhaling, right? So little baby bubbles as you ascend can help prevent this. Um, I think the main, maybe not the main time, but I think one of the more common situations that can happen where people will hold their breath and just like pop to the surface is usually if something's gone wrong. If, I don't know, I guess if you run out of air, but also like if you're panic, if something happens, if something scares you, and you kind of bolt to the surface, that's really when people aren't focusing on blowing bubbles, kind of calmly coming to the surface. So, another reason to try and remain calm no matter what's going on underwater, which sometimes is a really big ask. But always, always exhale with those little bubbles as you ascend to try and prevent any sort of barotrauma to your lungs. And then I think this is the one that gets a lot of attention too. So the other major injury that can happen as we ascend is this decompression illness, which is kind of the umbrella term for decompression sickness or the bends and this arterial gas embolism. Um, the way this injury happens is when, so again, if we're at depth, there's increased pressure, increased partial pressure, all of that gas is kind of like dissolved and like diffused throughout our body. But as we ascend, that gas kind of reaccumulates and forms gas bubbles again and comes out of solution. Hopefully, as we slowly ascend and do all of our stops like we're supposed to and wait all the time, those gas bubbles will slowly diffuse back to the capillaries in the lungs so that we can exhale gas. But if those little gas bubbles form wherever they are in our body, in our joint space, in our muscles, heaven forbid, in our vasculature, like in our veins or arteries, it can cause big problems, major problems, right? Like gas bubbles aren't supposed to exist anywhere but our pulmonary system, really. And so, an arterial gas embolism is essentially a bubble that exists in our arteries and acts like a blood clot. Honestly, anywhere that this little bubble goes is going to block blood flow from going to, anywhere further. So if this air bubble ends up in our brain, it'll cause stroke-like symptoms. If it occurs, in the lungs or near the heart, it can act like a pulmonary embolism, like a PE, and can cause some major pulmonary effects there. So the symptoms are kind of endless, and it all depends on where this bubble lands in terms of what symptoms you're going to see, but they're usually pretty dramatic. Um, the interface of the capillaries in the lungs is usually where we think that this gas bubble kind of forms and then makes its way into the vasculature. So it's usually going to be in the neighborhood of the heart or the lungs, and then maybe like a direct avenue to the brain. This usually happens right as divers surface or really shortly thereafter. So if anybody has a seizure or passes out or has stroke-like symptoms or has any sort of neuro symptoms at all in that time frame, it's kind of assumed that you have this arterial gas embolism, and it should be treated right away. This is obviously very dangerous, and can cause death. And I think, what does it say here? It's the second most common cause of mortality in divers behind drowning related incidents. So, of course, it's dramatic. This is not something that you're going to brush off and go, oh, they're going to be fine. So it's going to be something that you'll see and notice. I've had this like ethical dilemma, not ethical, I guess ethical discussion before. If somebody has this, would you maybe like shove a regulator back in their mouth and dive them again just to see if like that increased pressure would help with the bubbles? I don't know. Personally, I don't know that I would, but I guess it's an interesting conversation topic. Um, I know I have a slide later on, but just because we're on this topic, the treatment for this really is a hyperbaric chamber. You want to get somebody back into pressure so that you can pressurize that gas bubble, make it smaller, make it dissolve again, and then slowly decrease the pressure so that hopefully that gas will kind of dissolve out in the way that it's supposed to. But really, the best thing that you can do is get this person back into a pressurized environment as soon as possible. On the flip side of that, the other areas that bubbles can cause problems is obviously anywhere else in the body. The most common areas I think we think of are like joints and muscles. So people will maybe sometimes have like pain in a single joint or some discomfort in a certain area of their body. Again, this is when that dissolved gas kind of reforms a gas bubble inappropriately in a spot where it shouldn't be and causes pain and inflammation response and just kind of I think pain is probably one of the most common symptoms. But again, it kind of depends on where this bubble is in terms of what symptoms you'll see. Again, just like all of these, if you're following your dive tables, theoretically you shouldn't be having this. But even people who are, doing everything by the book, this can still happen. I don't think we really know why, but we've got from some of the research that's been done, we do know that there are some associated factors like age, if you're dehydrated, if you've been sick recently. Men have an increased risk as compared to women. And then a patent foramen ovale also kind of increases the chance so that if there's, just like with blood clots, if there's a bubble that forms, it can kind of cross over from from the venous to the arterial system and cause havoc on the whole other side of the body. So um, there is two different types. Again, musculoskeletal, which is pretty common, usually uncomfortable, but really not dangerous. And then the other type is serious, including things like CNS and pulmonary type symptoms. The treatment for this also is hyperbaric oxygen, so increasing that pressure to try and get these gases to dissolve back again and then slowly diffuse back out. Um, let's see. These symptoms, so the arterial gas embolism happens really quick when people get to the surface, like right as they surface or within like the first couple of minutes. The bends or the decompression sickness tend to happen within the first few hours of surfacing. So if you've gone on a dive and then someone starts to complain about pain somewhere, you can probably safely assume that they've got little air bubbles causing their symptoms, and that's what it is. It does say that the treatment is hyperbarics, but of course that kind of depends on, I guess, where it is and how bad the symptoms are. This graph is from one of the wilderness medicine texts, and it kind of lays out, I mean, obviously, a gas bubble can occur anywhere, but depending on where it is, what the symptoms might be, how dangerous it is, you can kind of guess things that are like in your joints and in your muscles are going to be sore and annoying, but probably not dangerous. But as you go down, obviously the lungs, maybe not ideal, but anything CNS, kind of a big deal. So the way this table is, it's kind of um, least dangerous, kind of to like more serious and dangerous as the table goes down. If I'm honest, for maybe like the musculoskeletal and skin symptoms, maybe even the pulmonary stuff if it's minor, I probably wouldn't necessarily recommend that somebody go directly to a hyperbaric chamber, although the textbook answer is, yeah, that probably should be at least offered. Um, but I think, I mean, as with anything in medicine, it kind of depends. If it's just uncomfortable, maybe you just like sit out the next dive or two and rest and hydrate at the surface. Shallow water blackout is not technically a diving injury, like a scuba injury. This happens mostly with free divers, but I wanted to cover it because it's obviously related, but it also is kind of a dangerous situation. Um, I mean, it's not really physics, but a little bit of physiology. As we breathe, of course, our oxygen and CO2 levels are always in flux. Um, if you guys remember, the trigger in our brain that stimulates us to take a breath is not our oxygen level decreasing, but it's our CO2 level rising, right? So if you hold your breath, you can hold it, for a good amount of time, voluntarily. But at some point, right, there's this like involuntary reflex to take a breath. And that's triggered, again, not by your oxygen level going down, but by your CO2 building up in your system. It's that CO2 level that triggers us to breathe. So I'm gonna go to this slide because I think it does a better job of kind of like visually explaining. So looking at the top graph, normally, if we dive, but also if we just hold our breath here, if you hold your breath, your oxygen will slowly, that's the red line, your oxygen will slowly kind of decrease until you take a breath, and then it'll go back, right? And then conversely, our carbon dioxide levels, if we hold our breath, that blue line, it'll slowly increase and at some point will trigger us to breathe unless we voluntarily take a breath, right? And then it goes back down. So you can see in this graph, if you were to dive, not just hold your breath, but hold your breath and go underwater, that our oxygen is going to decrease, our CO2 level is going to increase, and at some point, if we don't pop to the surface and take a breath on our own, our brain's gonna, you'll feel that kind of air hunger as our CO2 level starts to rise. You'll take a breath and everything will kind of go back to normal. Now, free divers sometimes will hyperventilate before they do their dive in hopes of extending their dive time. It sounds like a good idea, but there's this like dangerous situation that can potentially happen. So if you look at the bottom graph, kind of similarly, if you hyperventilate, your oxygen level kind of stays the same, right? It doesn't really affect our oxygen. But look what it does to our CO2. If we breathe really fast, we blow off a lot of CO2 and our CO2 level goes down. So now when we hold our breath, we're starting with kind of a bigger, I don't know, difference between those two numbers, right? So again, if you hold your breath, your oxygen level, the red line, will decrease. But look at that blue line, look at that CO2. Because we're starting lower, it'll still increase as we hold our breath, but this kind of danger zone happens. At some point, our oxygen will get low enough to where we'll pass out, we'll lose consciousness. But our brain isn't triggered to take a breath until much later when that blue line reaches that level. So, in this situation, if you hyperventilate too much, you kind of reach this awful situation of you'll pass out before your body triggers you to breathe. So now you're unconscious in the water, not breathing. I mean, not great. um, and so I have to assume that professional free divers are a little more nuanced and maybe understand not only their body but this science a little bit better. But somebody like, I don't know, you or me, or I don't know, maybe a bunch of friends who, want to have a contest about how long you can hold your breath. Somebody will suggest, hyperventilating, but just be careful because again, I don't think this is super common, but I think, maybe this is that teenage or college age kid, playing out at the lake, holding your breath contest type of situation. But all to say, it can be very dangerous. And this particular situation may not happen while you're scuba diving, but can happen with diving in general or swimming, I guess. So just a little something to be aware of. And just kind of interesting physiology too, I think. So now we're going to talk a little bit about how to treat some of these injuries. And I mentioned it a little bit along the way. Um, but if you have somebody who you think has a diving injury, in addition to all the questions that you're going to ask about their symptoms and how long has it been like that and when did it start, all that, you can ask some dive specific questions that might also help give you some clues. How long was your dive? What was your bottom time? Did you follow your tables? Did anything unusual happen? When did your symptoms start? Was it when you were descending, ascending? All of these things that might help you put the pieces together as to what may have happened. Additionally, there's a plug on this slide and on some of my other slides about DAN, the Divers Alert Network. For those of you who maybe aren't familiar, who don't dive, the Divers Alert Network, I like to think of as almost like the poison control for diving. They're a 24/7, I think worldwide, um, resource that you can call. And just like the Poison Center, they can offer suggestions about treatment and how to manage symptoms for anybody who may have an injury that occurred while diving. Even if you're not sure if it happened while diving or not, they're pretty good at making recommendations. And they can also help you find the nearest hyperbaric chamber if that's what's needed. So they're really great and are always available. So I think most dive boats and any diving shop or anything will have this number available, but it's pretty easy to find too with a quick Google. And then again, treatment for most of these, as we talked about them, talking about the descent injuries, there's a couple things that maybe you're not going to dive for a while, right? If you rupture your eardrum, there's not much to do other than let your body heal, avoid diving. If you have, gas bubbles, the decompression sickness, gas bubbles like in your joints or in your muscles, if your symptoms are kind of minor, it's probably just pain control and rest and avoiding diving. But for some of the more major things, right, the arterial gas embolism, or if you have like CNS type symptoms or pulmonary symptoms from your decompression sickness, the treatment again is hyperbarics. While you're trying to get to hyperbarics, you should try and make sure that your patient is hydrated, whether that's IV fluid or encouraging them to drink, because diving can make you kind of dehydrated, just like the dryness of the air and the fact that you're exerting yourself. So making sure that they're hydrated can help, and giving them supplemental oxygen at 100% FiO2 can be helpful even if they're not hypoxic. This will kind of help wash out some of the nitrogen and will help kind of, flood the body with oxygen to try and offset some of those gases while you're waiting for that pressurized environment. Again, the Divers Alert Network can be helpful at trying to figure out where the nearest hyperbaric chamber is and how to get there. I mean, most diving is obviously going to be maybe not always at the beach. I mean, you can dive in lakes and rivers too, but if you think about it, you're out either on the coast somewhere, off on a boat, maybe international. Getting to a hyperbaric chamber is probably not going to be quick. Hopefully it is, but thinking about some of the places that I've dived, it's not like there's like the dive shack, a restaurant, and like the hyperbarics right when you get back to the harbor. I mean, so it's going to take some time to get everybody back on the boat, get you out and evac in whatever manner that is most appropriate. So in the meantime, try and do all of the things that you can to help your patient with all the ABCs and all the normal stuff, but specifically the oxygen and the hydration can be really helpful as well. Um, Things to consider for transportation. If we think that there's, gas bubbles forming in people's bodies in places where there shouldn't be gas, if we go up in an airplane, it's kind of like the opposite of diving, right? When we're down underwater, that increased pressure kind of makes things smaller. But as we go higher, right? Now we're talking about like altitude type stuff. Um, the pressure is decreasing, and so those gas bubbles can expand. So consider maybe either flying low, either in a plane or a helicopter, or just making sure that it's a pressurized cabin. Um, Again, most dive boats, dive shops, and everything should be familiar with requesting this, but you can also ask the DAN network too, if they have special recommendations for transport, so that you can maybe not worsen an injury while you're trying to get somebody to their hyperbaric chamber. The sooner you can get someone to a chamber, the better for some of the more serious injuries. But again, just logistically speaking, it's going to take a little while. So the best you can do to temporize things in the meantime with the oxygen, the hydration, and all your other ABC type care is going to be helpful. And I think that is it for my very long, complicated dive lecture. Um, so, like I said, wasn't able to see the chat. So I don't know if there's any questions or comments or anything that I can answer for you guys about diving. But also, thank you so much again for popping in on a Saturday night.
I have not seen any questions in the chat. I am going to go ahead and
That's
stop our recording real quick.